Hello everyone. In this video, we are going to discuss about management of MDS, that is myelodysplastic syndrome. The classification of myelodysplastic syndrome is updated in the latest WHO uh, date on the classification of myeloid and lymphoid malignancy. However, I am not going to discuss about the newer classification here. This video is only for management of myelodysplastic syndrome. Now, before going into the drug therapies, what we need to understand is the treatment of myelodysplastic syndrome is based on the risk category of the patient. So for risk stratification, the score that is used is known as IPSSR. The score is IPSSR. The details of the score is not very important, but the components are important. So components include cytogenetic risk group, then blast percentage, hemoglobin, absolute neutrophil count, ANC, and platelet count. So these are the 5 components: cytogenetic risk group, blast percentage, hemoglobin, ANC, and platelet count. So blast percentage less than 2% is very good. Hemoglobin more than 10 is very good. ANC of more than 800 is good, very good. And platelet count of more than 1 lakh is very good. Okay, so these are the 5 components. Then regarding the cytogenetic risk group, for that you have to see this table. So the only thing you need to remember is deletion 11q and monosomy Y. These are the 2 very risk cytogenetic groups. Other than that, others are either good, intermediate, poor, or very poor. Complex karyotyping. Karyotype is has a very poor risk. So you have to apply this cytogenetic risk group according to the cytogenetics of the patient here in this IPSSR model, and you have to calculate the total score. And once you calculate the total score, then you will be able to find out which risk group the patient belongs. Okay, so patient can be divided into low risk group, very low risk group, intermediate risk group, high risk group, or very high risk group. Based on this risk stratification, the management will vary and also the prognosis. Okay, so you can see here the median survival for patients for low risk group is 8.8 months. For very high risk group, it is 8.8 years. For very high risk group, it is 0.9 months. Okay. Median survival in years, you can see low risk group it is 5.3 years. For very high risk group, it is only 0.8 years. Okay. Now, once you stratify the patient based on the risk stratification, then comes the management. Okay, so before going into the management algorithm, first of all, we should understand what are the drugs that we have in our hand to use in patients with myelodysplastic syndrome. So first group of drugs is hypomethylating drugs. So the hypomethylating drugs are DNMT, DNA methyl transferase inhibitors, DNA methyl transferase 1 inhibitors. This includes azacitidine, decitabine, and there is a newer combination drug that is decitabine plus cedazuridine. This is oral drug. Remember, hypomethylating agents, these are the only group of drugs that have shown to improve survival in high risk patients, in higher risk MDS. So the only drug that has improved survival in higher risk MDS, in higher risk MDS. The most important one is azacitidine, which has shown the maximum response. So azacitidine can be used either subcutaneous or it can be used as IV. The dose is 75 mg per meter square per day for 7 days. This is one cycle. Like this, you can give monthly cycles. Okay, you can give monthly cycles, and the response that is seen with these drugs are around 17%. This is a complete response. This is complete response rate. in higher risk MDS groups. In higher risk MDS group. Okay. So most commonly used drug is azacitidine in this group, hypomethylating agents, and the complete response rate is 17%. However, to have a survival benefit or to have a symptomatic improvement, this 17% doesn't hold true. Many of the patients will become transfusion dependent or they will have a symptomatic improvement. Okay, but the complete response is in only 17% of cases. Okay. I forgot to tell about the mechanism of action in detail. Actually, this the function of the normal function of DNMT is DNA methyl transferase is to add methyl group to cytidine residue. So DNAs will have this cytidine residue, and the function of DNA methyl transferase is they will add the methyl group. Addition of methyl group will cause the addition of the methyl group will cause uh, inhibition inhibition of promoters. So ultimately, the DNA replication followed by the transcription and all those steps will be inhibited. And once you inhibit this DNA methyl transferase, once you inhibit by hypomethylating agents HMA, they will inhibit the DNA methyl transferase. And once DNA methyl transferase is inhibited, this methyl group will not be attached to the cytidine residues on DNA. Okay. So if the methyl group is not attached, then promoter will be free. It will be able to do its function, and there will be normal replication, or gene expression. The gene expression is enhanced, and this will lead to normal hematopoiesis. Normal hematopoiesis. That is the mechanism of action of hypomethylating agents. Okay, and I told the drug azacitidine is used most commonly, and this has shown a good response in higher risk MDS. Now coming to what are the side effects? The most important side effect is bone marrow suppression. That means they will cause neutropenia, and thrombocytopenia. Okay. And the latest drug that I told, decitabine plus sidazurudine plus sidazurudine. This is a newer oral drug that is FDA approved for CMML and MDS in the intermediate 1, intermediate 2, and high risk groups. Okay. So MDS intermediate 1, intermediate 2, and high risk groups. It is not approved for lower risk group patients. Okay, so this is the newer drug. Okay. So apart from that, what else? We have additional drug, venetoclax. This can be used plus or minus along with the hypomethylating agents. This I have also told you in management of AML that the patients, the AML patients who are not fit for intensive chemotherapy, we give azacitidine plus venetoclax or hypomethylating agent plus venetoclax. Similarly, in these high risk MDS cases, uh, venetoclax can be added in patients, can be added along with hypomethylating agents for these higher risk MDS groups. Okay, and if the patient fails on hypomethylating agent, still you can give a trial of venetoclax. Okay, still you can give a trial of venetoclax. And remember, if this kind of patients, if the high risk MDS group patients, if they are not responding to hypomethylating agent, the only option that we have is allogenic hematopoietic stem cell transplantation. Okay, other than that, the survival is very poor. Now coming to some other drugs that are basically used for low risk MDS groups. The first drug is lenalidomide. It's a thalidomide congener. The mechanism is they will modulate this E3 ubiquitin ligase cereblon activity. So this one. So they will modulate this E3 ubiquitin ligase cereblon activity. Now this will degrade the IKZF1. This will lead to degradation of IKZF1, Degradation of IKZF1 will cause increase in GPR68 and increase in RCAN1. Okay. So increase in GPR68 and increase in RCAN1, that will ultimately lead to increase in calpain. This is calcium calpain, and calcineurin. This is calcineurin. This increase in calcium calpain will cause increased apoptosis of MDS cells, and increase in calcineurin will cause decreased survival of MDS and AML cells. For inhibition of calcineurin will cause decreased survival of MDS and AML cells, and increase in calcium calpain will cause increased apoptosis of MDS cells. So this point is important. They cause modulation of E3 ubiquitin ligase cerebellum activity that will ultimately lead to increased apoptosis of MDS cells and decreased survival of MDS by AML cells. Now, lenalidomide is it is FDA approved for IPSS low risk or intermediate 1 risk patients. So this is FDA approved for low bar intermediate 1 risk MDS patients with deletion 5q. With deletion 5q. The response was seen in 67% of the patients who became transfusion independent, in around 4 weeks. So you can see the response in around 4 weeks, and 67% of the patient become transfusion independent. But they have a very specific indication, that is, patient should have a deletion 5q plus or minus other cytogenetic abnormalities. Deletion 5q has to be there to give this drug, Leonadomide. The side effects are myelosuppression, thromboembolism, and also there is a slight risk of secondary AML. Because of the risk of thromboembolism, whenever you give lenalidomide, you should also give antiplatelet agents like aspirin. Okay, so len is more commonly used in patients with multiple myeloma, and routine use of aspirin is recommended in them. Coming to the next drug, that is, this drug is known as luspatercept. This is a newer drug. So what is the function of luspatercept? If you see the structure here, this is the structure of luspatercept. You can see it has two components. One component, first, the red one, is this is a modified extracellular domain of activin receptor 2b. Okay, so it's a extracellular domain, modified extracellular domain of activin receptor 2b. This activin is a TGF beta superfamily protein. This is TGF beta superfamily protein ligand. You can tell the ligand, TGF beta superfamily ligand. That means it will modulate the TGF beta signaling. And this luspatercept has a domain that is that will have the receptor for this activin. Okay, so here it will bind this activin, so that the activin will not bind to the cells and cause suppression of erythropoiesis. And the other component is this blue one, is the Fc domain of IgG1 antibody. Okay, so if you see in this diagram, you can see, so this is the drug. Reblozil is a brand name. So it will bind to the TGF beta superfamily ligand, that is activin, and it will prevent binding of this activin to the cell surface receptor. And because this binding doesn't happen, it will ultimately lead to reduction in SMART2 and 3 signaling. This SMART2 and 3 signaling in patients with MDS and in patients with thalassemia, this SMART2 and 3 signaling causes inhibition of erythropoiesis. Okay, and because this luspatercept is suppressing this SMART2 and 3 signaling, it will cause erythroid maturation. That is the function in patients with MDS and in some cases of beta thalassemia. Apart from this mechanism, there is one more mechanism That is, you can see here, it inhibits GDF11. It inhibits GDF11. GDF11 is also similar to SMART2 and 3 signaling. This also causes inhibition of erythropoiesis, and luspatercept, by reducing the GDF11 signaling, GDF is growth differentiation factor 11 signaling, it will cause erythroid maturation. Okay, so from this you can understand that luspatercept is a ligand trap. It's a ligand trap because it is trapping the ligand, that is activin. Activin is a TGF beta superfamily ligand. Okay, and by inhibiting the function of activin, it is causing reduction in GDF11 activity and SMART2 and 3 signaling. And by both these mechanisms, it is causing erythroid maturation of erythroid or erythropoiesis. Luspatercept has been studied in MDS, studied in beta thal, and also in primary myelofibrosis. Primary myelofibrosis. And this is the mechanism of action. Okay. Now coming to so this is FDA approval of luspatercept. It is approved for patients with low risk MDS, RS, or MDS, MPN, RST. So it is also approved for low risk MDS, but this MDS would have ring sideroblast. This also has a specific indication, like in Leonadomide I told, low risk MDS with 5q deletion. This is for low risk MDS with ring sideroblast. And also MDS MPN overlap syndrome, that is MDS MPN ring sideroblast with thrombocytosis. For that also this is approved. Okay. So this is given, if you see the trial name is Medalist trial for MDS, and this is given every 21 days. So it is given sub-Q every 3 weeks, sub-Q every 3 weeks. The response that is seen in the response is seen in around 38% of patients. 38% of the patients who became transfusion independent. I told for lenalidomide it is 67%. For luspatercept it is 38% response. Side effects for luspatercept is very like non-specific side effects. They will have fatigue, headache, MSK symptoms like musculoskeletal pain, arthralgia, then some vestibular symptoms like dizziness, and then some GI symptoms like abdominal pain, diarrhea, and vomiting. So these are some of the side effects which are very non-specific for luspatercept. Okay. This is about luspatercept. One point I forgot to tell in leonadomide, that this drug, it is very less effective. It is less effective if the platelet count is less than 50,000. Remember the patients, these MDS patients who have this deletion 5q, usually these patients will not have thrombocytopenia. These patients will have either a normal platelet count or a thrombocytosis. So in any given scenario, case of MDS, if they have a normal platelet count or high platelet count, then there might be a possibility of deletion 5q in that case. Okay. And studies have shown that if the patient has a low platelet count of less than 50,000, lenalidomide is not that effective. Okay, and the trial name is Medalist trial for luspatercept in MDS. The next is IDH inhibitors. So if MDS patients have IDH1 or IDH2 mutations, then you can give the drugs like ivosidenib, similar to AML. In AML also I told, if they have these mutations, then you can give ivosidenib is IDH1 inhibitor, enasidenib is IDH2 inhibitors. So these drugs can also be given. Apart from that, in resource limited settings, they have found that low dose cytarabine can also be given to patients with MDS. Okay. So these are the drugs. First we discussed about the hypomethylating agents, which can be given to higher risk MDS patients or to lower risk MDS patients if they do not respond to these drugs. Then we discuss about the lenalidomide, luspatercept, IDH inhibitors. These drugs are given usually for the low risk groups and they have a very specific indication. For len, it is deletion 5q. For luspatercept, it is ring sideroblast. For IDH inhibitors, the specific drugs. Then we'll see uh, the next group is immunotherapy. Next group is immunotherapy. Immunotherapy means use of anti-thymocyte globulin ATG or cyclosporine. Now you must be knowing that these drugs are used for patients with aplastic anemia. Okay? And immunotherapy has some role in patients with MDS, those who have a hypocellular MDS, count of less than 10% in marrow, and age, age is less than 60. Age is less than 60 years, and they will have either a karyotype, normal karyotype, or trisomy 8. If everything is fitting, if all these things are fitting, then you can give a trial of immunotherapy, that is ATG and cyclosporine can be given. ATG plus minus cytosporine, cyclosporine. Okay. So the main indication is hypocellular MDS. Will behave similar to aplastic anemia. So some of the cases they might respond to immunotherapies. One more thing is if the patient has HLA DR15, they'll have a good response to this immunotherapy. Now coming to supportive care, transfusion and iron chelation. Studies have found that if the MDS patient is requiring PRBC, once in every 8 weeks, that will have a bad prognosis, that will have a poor prognosis. Okay, and they have also found that if they have a ferritin, of more than 1000 nanogram per ml, that will also have a poor prognosis. Ferritin increases because of repeated blood transfusion. So they have found that the patients who are actually transfusion dependent and they have a very poor prognosis. The target hemoglobin to be kept through transfusion is around 7 to 8 gram per deciliter. Maybe higher if the patient has additional cardiopulmonary disturbances. Then we may target a higher hemoglobin level. In otherwise, all patients you can target hemoglobin of 7 to 8 gram per deciliter. For iron overload, though ferritin can tell us about the status of iron status of the body, the status of iron overload. However, there are newer methods like doing a MR, T2 MRI of liver, T2 MRI of liver, or heart, cardiac MRI. They can also tell us about the status of iron overload. And if the patient is having iron overload, you have to start the patient on chelation therapy. You have to start them on chelation therapy. Now we have 3 iron chelators: deferoxamine, deferasirox, and deferriprone. Deferoxamine is usually given as IV. Deferasirox is oral. Now, if the patients are having iron overload, you have to start them either on deferoxamine or deferasirox. Deferoxamine or deferasirox. However, if the patient has a creatinine clearance of less than 40 ml per minute, then you have to avoid these drugs. You cannot give these drugs. Deferriprone, though it is used in patients with iron overload and mostly used in patients with thalassemia. Ephedrone is usually avoided in patients with MDS because it has a high risk of agranulocytosis. High risk of agranulocytosis, so this is always avoided in patients with MDS. Efruxifermin or deferoxamine can be given. Deferoxamine is an oral drug, so that is more preferred. More of these drugs we'll be discussing in thalassemia section. Coming to hematopoietic growth factors, whether hematopoietic growth factor has a role in patients with MDS. Studies have found that erythropoietin stimulating agents like apoietin alpha or darbepoetin alpha, apoietin or darbepoetin is a recombinant EPO analogs. They have shown some response if the patient has serum EPO level of more than 200 to 500. You can remember if it is less than 500, EPO level is less than 500 units per liter, then erythropoietin stimulating agents can be given. Okay, it can be given. However, before giving erythropoietin stimulating agents, your iron stores should be adequate. Iron stores should be adequate. Side effects include risk of hypertension, thromboembolic events, and there is a small risk of secondary AML. Okay. Then role of GCSF, granulocyte stimulating factor or granulocyte monocyte stimulating factor. They have shown to increase the absolute neutrophil count in up to 60 to 90% of cases. Up to 60 to 90% of cases. However, there is also a increased risk of leukemic transformation. So that's why it is not commonly used. GCSF or GMCSF, they are not commonly used because there is also a risk of leukemic transformation. And the response that is seen is around 60 to 90% of cases. Then coming to thrombopoietin analogs, TPO, RA agonist, that is eltrombopag and romiplostin. These are useful if the serum TPO level is less than 500 picogram per ml. So if EPO is less than 500 units per liter, then ESS would be given. If TPO levels are less than 500 picogram per ml, then TPO RA agonists are useful. However, doing a serum TPO level is not widely available. So if the patient has thrombocytopenia, you can give a trial of TPO RA agonist. Side effects include increased risk of leukemic transformation and bone marrow fibrosis. Also, there is a risk of rebound thrombocytopenia while stopping this TPO-RA agonist. Okay. Then coming to the role of allogenic hematopoietic transplantation. Remember allogenic hematopoietic transplantation. This is the only curative therapy available. Only curative therapy available for MDS. Allogenic hematopoietic stem cell transplantation is the only curative therapy available for MDS. This can be used upfront for high risk MDS. Upfront use if the patient is transplant eligible and the patient has a match, then it should be done upfront. And also it is used for low risk MDS not responding to other therapies. If the patient has TP53 mutation, even doing a hematopoietic stem cell transplantation, the response is only less than 10%. So TP53 mutation has a very, very poor prognosis. One more point you have to remember is if you are doing it in children, or young patients or young patient who have a de novo MDS, you should always rule out Fanconi anemia. Always rule out Fanconi anemia by doing stress cytogenetics. Okay, you have to rule out Fanconi anemia by doing stress cytogenetics. You must be knowing that Fanconi anemia is the inherited bone marrow failure syndrome which has the risk of MDS, AML, but will also have various phenotypic abnormalities. But around 20 to 25 cases of Fanconi, they may not have a phenotypic abnormality and they can directly present with either MDS or AML. So if you're doing, if the patient, if a child or young patient has MDS, then you have to rule out Fanconi anemia because if these patients, if you are taking for stem cell transplantation, you have to use a different conditioning regimen. You have to use the different conditioning regimen because with standard conditioning regimen, they will have a higher toxicity. So that's why it is always recommended to rule out Fanconi if you are taking a child or young patient for allogenic hematopoietic stem cell transplantation. Okay. So now we have studied all the modalities. Now we'll be just summarizing the management. So here we'll just summarize or the treatment algorithm. So once the patient is diagnosed with MDS, I told you have to do IPSSR, risk stratification, and then divide them into low risk group or high risk group, low risk or high risk group. In the low risk group, if the patient has only anemia, yes, the patient has only anemia, then you have to check whether the patient has a deletion 5q. If the patient has deletion 5q, you give them len, I told, and also you can give erythropoietin stimulating agent if the EPO is less than 500. If it doesn't respond to this, if no response, then you can give hypomethylating agent, immunosuppressive therapies, or you can give suppressive therapy, or you can give erythropoietin stimulating agents if you have not used. Okay. Then if the patient doesn't have deletion 5q is not there, look for serum EPO. It is less than 500. If serum EPO is less than 500, you give them ESA plus or minus GCSA. Doesn't work, if failed, then you can give hypomethylating agent or immunosuppressive therapy if it is fitting into the indication of immunosuppressive therapy, that is hypocellular marrow. Then if the EPO levels are normal, you see whether there is any component of ring sideroblast, whether ring sideroblast is there or not. If it is there, then you can use luspatercept. And also if the patient has less than EPO of less than 500, still the patient has ring sideroblast, you can also give luspatercept. If it is failing, again you can give HMA, immunosuppressive therapy, trial of ESA, or even trial of LEN. So these are all. If the patient doesn't respond to these first line drugs, then these are all the other options that we have. If deletion 5q is there, if the patient is low risk and the patient has deletion 5q, give LEN. If EPO is less than 500, give ESA. If there is zinc sideroblast, give luspatercept. If the patient doesn't have any of this, you have to go for HMS or immunosuppressive therapy if there is hypocellular marrow. Trial of GCSF, trial of TPO agonist. GCSF and TPO if the patient has other cytopenias. Okay. Apart from anemia, if the patient has other cytopenias, you can give a trial of GCSF and EPO. Okay. And if this fails, of course, you have only option of allogenic hematopoietic stem cell transplantation. you have to enroll the patient in clinical trials. Here also, if this fails, then you have to go here. I hope it is clear. So if it is a low risk, first look for, if it is isolated anemia, then you see whether you have deletion 5q, EPO less than 500 or ring sideroblast, and accordingly you give treatment. If the patient has other cytopenias along with anemia, then you have to think of giving GCSF, TPR agonists, and other therapies like hypomethylating agents or immunosuppressive therapies if there is indication. If these first line drugs fail, then you have to give again HMS, hypomethylating agents. If nothing is working, then you have to take up the patient for allogenic hematopoietic stem cell transplantation. High risk group, it is very simple. If the patient is transplant candidate, yes. If the patient is transplant candidate, then you have to take off the patient for allogenic hematopoietic stem cell transplantation. If the patient is not transplant candidate, then you have to give HMA. Okay. So if it fails, then you have only option of palliative care or enroll the patient in clinical trial. Allogenic stem cell transplantation, if relapses, you can do a second transplant. Or donor lymphocyte infusion trial, or you can give a second transplant. Still it fails. If still fails, then supportive care and enroll into clinical trial. So this is the final algorithm for management of myelodysplastic syndrome.